HPV is the most common sexually transmitted infection in the United States, with 6.2 million people infected with genital HPV annually. 150 types of HPV have been identified, with 40 types of HPV infecting the genital areas. 90% of genital warts are caused by HPV 6 and HPV 11, producing non-oncogenic, benign, low-grade abnormalities. 70% of cervical cancers are caused by HPV 16 and HPV 18, oncogenic, high-risk HPV variants. HPV infects anal, cervical, oropharyngeal, penile, vaginal, and vulvar regions, with oropharyngeal the most commonly infected area in men, and cervical the most commonly affected area in women. All cervical cancers are caused by HPV. Cervical cancer incidence varies drastically by location in the United States, with the highest rates in the southeastern states, which correlates with a low vaccination rate of only 12 to 28% in girls ages 13 to 17 years old. The highest vaccination rates for girls 13 to 17 are in the Northeast, to include Washington State and also Hawaii, with a rate of 41 to 58%. 25 states have enacted legislation to educate the public about HPV vaccination, emphasizing the direct correlation between cervical cancer rates and HPV vaccination rates. States with higher incidence of cervical cancer have lower rates of vaccination. It is recommended that adolescent females 11 to 12 years old receive 3 doses of HPV-2 or HPV-4 vaccine. It is further recommended that females 13 to 26 years old should receive the vaccination or catch-up vaccination if it was not previously administered at the recommended age. In 2010, only 3 out of 10 girls received HPV vaccination. In adolescent males, the HPV-4 vaccine should be given between 9 and 26 years old, with 11 to 12 years old being the recommended age. HPV-2 and HPV-4 are not live vaccines and can be administered to immunocompromised adolescents. HPV vaccination is not recommended in pregnancy. If an adolescent becomes pregnant during the vaccination schedule, the vaccination series should be completed after delivery. Adolescents with low access to health care are more likely to not be vaccinated. These include uninsured adolescents, adolescents with parents who are uninformed or unaware of HPV vaccination, adolescents with parents who purposefully choose not to vaccinate their children due to health and/or religious beliefs, homeless or highly transient adolescents are at risk for not completing the recommended vaccine series. Adolescents with parents fearing vaccine side effects or encouragement of sexual behavior in adolescence. "4,000 women will die each year from cervical cancer. The vaccine will not affect fertility, and the HPV vaccine is safe and has been tested carefully. Health insurance covers the cost of HPV vaccinations. Vaccines for Children, or FVC, covers the cost of vaccines in uninsured adolescents. Children younger than 19 years old qualify for the vaccine through FVC programs if they are American Indian, Alaska Native, without health insurance, Medicaid eligible, or underinsured. So why are parents still not vaccinating their children? Parents lack knowledge. They have safety concerns and fear of side effects. They don't feel that it's necessary, and they feel if their child is not sexually active, they don't need the vaccine. The current vaccination rate for adolescent girls ages 13 to 15 is 28.1%. The current vaccination rate for adolescent boys aged 13 to 15 is only 6.9%. It is the goal of Healthy People 2020 to increase these rates to 80% to reduce cervical cancer rates by decreasing HPV infections. Widespread vaccination with Cervarix or Gardasil has potential to reduce cervical cancer incidence by as much as 2/3, while Gardasil 9 could prevent an even higher proportion. So how do we increase HPV vaccination rates? Using the best evidence to address these goals, we determine the need for patient immunization navigators, provider-focused interventions, and school-located vaccination programs to increase HPV vaccination rates among adolescents in the United States. The Patient Immunization Navigator Program implements a tiered protocol for immunization tracking, telephone or mail reminders, and home visits if patients remained unimmunized or behind on the preventative care visits. Using this method, there was an increase in vaccination rates and an increase in preventative care visits. Provider-focused intervention uses a provider-centered multi-component intervention to create sustained improvement in HPV vaccination rates. It utilizes focused education by providing education to change the way providers view the importance of HPV vaccination, frame discussions around HPV vaccines, and respond to parents' initial hesitation toward the HPV vaccine. School-located vaccination programs utilizes a school location for the vaccine program to improve immunization delivery to adolescents. Provide information about the vaccination program to parents at school registration and via packet sent home with students. Ask parents to provide written consent for their child to be vaccinated at school. Request health insurance information and the student's vaccination record. Contact New Hampshire's Vaccine Association to obtain a supply of HPV vaccines free of charge for uninsured children under age 18. Plan to vaccinate over 3 clinic days, with the interval between clinic dates to accommodate the HPV vaccination schedule. These 3 interventions will allow us to coordinate care through a multidisciplinary approach, working together towards the common goal of increasing HPV vaccination rates among adolescents. So how do we get the public involved? Employ mechanisms that capture the public's interest and contribute to health literacy. Utilize pediatrician offices to offer pamphlets, flyers, and information kits, and encourage vaccination. The school nurse can distribute information and scheduling of vaccines at the beginning of the school year. They can hold PTO meetings or open houses, or distribute take-home flyers. They can hold bilateral stakeholders meetings and allow community members to learn about the importance of HPV vaccination and to ask questions. We must collaborate across all sections and levels. Population health is a shared responsibility and accountability for health outcomes.